Good evening, everyone. We welcome you all to OrthoTV online international webinar. This webinar has been brought to us by an unrestricted educational grant from Zydus Synovia, good evening, everyone. The makers of Hylasto S. So, without further ado, I hand over to our today's moderator, Dr. Salim Patel, who's the senior advisor in Zydus and also a consultant orthopedic surgeon from Mumbai, to introduce our speakers and the topic. Over to you, Dr. Salim Patel.
Yeah, good evening, Neeraj. Thanks a lot. Good evening, everyone. On behalf of Zydus, I welcome you all to this international speaker program, which we are conducting here on OrthoTV. OrthoTV has been our ardent supporter in conducting these programs. Today, we have a very interesting webinar session. And to share the views of the webinar, I would first start by introducing our speakers and our faculty for the day. Today, our webinar is going to be mostly about the latest management of osteoarthritis and the new trends in the management using the next-gen viscoadaptive supplement, which is Hylasto S. Our panelist for today is Dr. Amit Kanta Mitra. He is a senior consultant orthopedic surgeon from the Singapore General Hospital, a senior consultant orthopedic surgeon in sports services at the Singapore General Hospital, visiting consultant to the Singapore Armed Forces, a clinical senior lecturer of the National University Hospital, honorary visiting consultant to Sports Medicine Research and Sports Science Center, has been awarded by the Ministry of Health of Singapore for the Health Manpower Development Program in 1988, has more than 5 number of publications in research trials published in renowned index journals. Welcome, Dr. Mitra.
Thank you.
Our speaker for today is Dr. Po Seng Yu. He's a senior consultant orthopedic surgeon from Singapore General Hospital. He's an adjunct assistant professor in the Department of Orthopedic Surgery at the NUS Yong Lu Lin School of Medicine and an adjunct assistant professor at the Duke NUS Medical College, the RCS from Edinburgh. He's a Medical Protection Society member and also a member of the Singapore Orthopaedic Association. Has N number of laurels to his name, the important one being the Hart Award in 2014 and 17 for outstanding clinical services, the Singapore Health Doctors Award in 2014, then the Singapore General Hospital Long Service Award for 10 years in 2014 again. He's also the recipient of the HMDP Award of Singapore General Hospital in Orthopedics. In sports medicine, he has been awarded with the hip injuries related seminars from 2011 and also the recipient of the Asian Traveling Fellowship in 2011. Dr. Po also has more than 10 publications and research trials published in renowned and indexed journals. I would now hand over the session to Dr. Po to take us through the proceedings. Over to you, Dr. Po.
All right, thank you, Dr. Salim. Okay, let me share my screen now.
Yeah.
All right, are you able to see my screen?
Yes, sir.
Yes.
All right, very good.
Okay,
so my talk is on the new trends of management of osteoarthritis with the next generation viscoadaptives. Okay, so we talk a little bit on osteoarthritis. Yeah, so osteoarthritis is essentially a degenerative joint disease where there's wear and tear of the cartilage within the joint. It is the most common form of arthritis, and we commonly see that in the knees, hips, as well as the hands. You can see that in this picture. Obviously, you can see a tricompartmental osteoarthritis of the knee. The main effect is that it's progressive. It results in pain, stiffness, swelling, as well as disability. Essentially, it acts like a form of joint failure. So taking some data from India, you can see the OA prevalence out of a study that's been done and published in the Indian Journal of Orthopaedics in 2016. This is a community-based cross-sectional study of the prevalence of primary knee osteoarthritis in India that is taken by sampling 5 sites throughout India with high population centers. So you can see that the prevalence of osteoarthritis is about 28.7%. And we tend to see a higher percentage of osteoarthritis in patients who are obese. This is 33% compared to the normal population, which is about 28%. And in the older population, where you see that it's about 54%. So nearly half of all patients that are more than 70 years will have some degree of osteoarthritis. So this is truly a big problem, and it also presents a social economic challenge because osteoarthritis leads to problems associated with pain and disability. So let me talk a little bit about the synovial fluid within the knee joint. Essentially, the synovial fluid is an ultrafiltrate of blood plasma with hyaluronic acid and glycoproteins. So it's a viscous fluid that's secreted by the synovial membrane into the joint cavity and it coats the cartilage surface. It provides nutrients for chondrocytes as well as is responsible for the excretory pathway of chondrocytes. Also, the hyaluronic acid component provides viscoelastic properties. In other words, it is responsible for both lubrication as well as shock absorption during movement. And it has anti-inflammatory as well as analgesic effects. So we talk a little bit on the viscoadaptive properties of hyaluronic acid. What that means is it is a form of as we know, hyaluronic acid has viscoelastic properties, and different types of movement require utilization of different properties of the viscoelasticity, hence the term viscoadaptive. So if you take a look at this, when a patient is initially resting or standing, in other words, when it's sedentary or low impact activities, you really need a high degree of viscosity. The reason is because you want the energy that's transmitted across the knee joint to be evenly distributed. However, when you're walking or running, these are high impact activities. Elasticity is more important because it allows then the knee to absorb energy safely, and the function of the hyaluronic acid at this point is more of shock absorption. And the hyaluronic acid is responsible for this viscoelastic property of synovial fluid. In addition, hyaluronic acid plays an important analgesic effect. It reduces the expression of pro-inflammatory cytokines such as IL-1, TNF-alpha, and in so doing reduces the sensitization of articular pain receptors. It is also responsible for reduction of the synthesis of substance P and bradykinin, which is important in the pain pathway. In addition, it has effects on insulating pain receptor endings, as well as entrapment of nociceptive molecules. All in all, this helps to reduce the pain that is felt within the knee joint. So if you look at the concentration of hyaluronic acid and age, we know that the viscoelastic properties of hyaluronic acid really depends on its concentration and the quality. So if you look at cadaveric as well as in vivo studies on synovial fluid, the HA concentration actually decreases with age. So what is the role of viscosupplementation then? What we intend to do in this case is the injection of exogenous hyaluronic acid into osteoarthritic joints so as to restore the properties of young, healthy synovial fluid. And in so doing, what we want to do is restore the viscoelastic properties of synovial fluid, restore the anti-inflammatory and analgesic effect that it provides, as well as it's been shown that it provides a positive feedback on endogenous hyaluronic acid production and is postulated then to reduce the degradation of cartilage. The effect of this is to provide longer-term pain relief for osteoarthritis, as well as spares the chronic use of pain medication, such as NSAIDs with systemic side effects. So if we look at the management and treatment of osteoarthritis, it follows a ladder depending on the severity. In the mild forms, non-pharmacological interventions will suffice, such as education, exercise, injury prevention, weight loss, or the use of orthotics. As the pain starts to become more of a problem, we can consider topical, such as NSAIDs, capsaicin, or lidocaine patches, and then oral medication, including Panadol, NSAIDs, opioids, and even some form of antidepressant. However, if this does not work, we look at intra-articular form injections, and this could be in the form of corticosteroids, hyaluronic acid, or PRP injections. Finally, if all else fails, then we go to the option of surgery, which is not so acceptable to all patients. But nevertheless, sometimes surgery is required, and this can be in the form of an arthroscopy, an osteotomy, or a knee replacement. So how do I select patients for viscosupplementation? Usually, I like to use it in patients who have mild to moderate OA, chronic pain due to the OA, no acute inflammation. In other words, we don't want the patient to have severe effusion during the point of injection, patients who have failed other forms of conservative treatment, patients who are unable to tolerate side effects of other pharmacological agents, for example, the gastrointestinal risk, the renal or cardiac complications arising for NSAIDs, or patients who have severe osteoarthritis but refuse or are not fit for surgery. The effect of viscosupplementation is to reduce symptoms, provide pain relief, and improve mobility. So let's look at some of the intra-articular injections that can be performed. Most people are quite familiar with steroids. There's fast pain relief, but the problem is that the relief is not prolonged. So it's extremely useful for inflammatory flares. However, there are adverse effects, most important of which is infection. For this reason, it is contraindicated, especially in patients who have diabetes. For hyaluronic acid, it has a prolonged effect of pain relief. The efficacy is really, there's a wide inter-individual variation, but most studies tend to suggest that it is efficacious for the reduction of pain. In addition, it tends to have a longer lasting effect than corticosteroids, although again, there is inter-individual variation. Most importantly, however, hyaluronic acid is well tolerated with minimal side effects. Something in vogue is the injection of platelet-rich plasma. However, to date, there's a low level of evidence, and the studies all show small sample sizes and wide variability in the treatment efficacy. For this reason, no definitive recommendations can be made. And in fact, even in Singapore, there is no routine recommendation of PRP injections for knee osteoarthritis. So how do I do the injections? I commonly do these injections either in the knee or hip. We follow an aseptic technique, so I like to do that in a procedure room or sometimes in an operating theater. What happens then is we clean and drape. I use iodine to clean it, and then after that, I'll clean off the excess iodine with cetrimide, and then just leave iodine around the area where I do the injection. There's an optional use of local anesthetic. In the knee, I used to do suprapatellar pouch injections, but now I've moved towards letting the patient sit up and hang his leg over the couch, and then we just inject through the lateral parapatellar approach, similar to your arthroscopic portal. And you just need to be careful when you do the injections. Sometimes if you advance your needle too deep, there may be a lot of resistance. That may be because the needle is in the ACL. So all you need to do is just withdraw the needle a little bit, and then after that, complete that injection. Usually the injection is a very smooth flow of the gel. In the hip, you have to have some form of guidance, either fluoroscopic or ultrasound. I usually do mine through fluoroscopic guidance, so I do that in the operating theater. What we do then is we use a 18 gauge long needle, and what we do is under fluoroscopy, I advance the needle akin to what I do for proximal anterior lateral portal for hip arthroscopy. Essentially, what you want to do is essentially hit the head neck junction, and then you slowly migrate onto the anterior surface of the femoral neck. And I usually start the test injection with 5 mL of saline, and once I get good flow, what I then do is change it to the hyaluronic acid injection, and then usually it's quite a smooth flow from there. But you can also do it under ultrasound guidance in a routine procedure room. So some of the risks, generally hyaluronic acid injections are very safe, and many studies have shown a good safety profile. However, some of the complications are local flare. In my hands, it's probably less than 1%, where patients get pain, inflammation, swelling, rash, or itching. It's most important not to do the injections when there's acute or significant effusion. As long as you follow that rule, usually it's not such a big problem. There have been rare reports of systemic allergic reactions, and of course, infection, including septic arthritis. But again, this is rare if aseptic technique is adhered to. So now we talk a little bit about the options of hyaluronic acid, and I'm going to introduce you Hylasto S, which is essentially sodium hyaluronic gel with sorbitol. So if we look at the evolution of viscosupplementation, the first generation and second generation, both of these are harvested from rooster combs. The first generation is multiple shots, and then slowly we progress to a single shot injection. However, as we move up, the third generation, these are biofermented, which means they are recombinant hyaluronic acid production using various engineered strains of bacteria as hosts. So this avoids the problem of sensitivity, and we are able to produce it on a larger scale. In addition, you can use, in the third generation, these are multiple shots, but they have also evolved to the fourth generation single shot injections. Hylasto S, however, represents a fifth generation form which has viscoadaptive properties, and I'll talk a little bit more of this in the later slides. So let's go again. Hylasto S, essentially, it's a 2 ml formulation that is 40 milligrams of hyaluronic acid 2%. it has sorbitol added to it. This is 80 milligrams, which acts as an antioxidant, the importance of which I will discuss later. It comes in as a glass syringe, and it can be stored in room temperature 2 to 25 degrees, and it's developed in Switzerland. So there are 4 important points about Hylasto S. First, there's a patented viscoadaptive property. It is able to break the oxidative loops, improve cartilage elasticity, and it has unique viscoentalgic effects. I'll go into them one by one. So if you remember the viscoadaptive property we've discussed already, essentially we want the viscoelastic properties of synovial fluid because it's important in proper functioning. Different types of movement require utilization of different properties of the viscoelasticity. In low impact movement or sedentary movement, what you want more is the viscosity of the synovial fluid. And this is important for friction limitation and damage to the cartilage. However, if there's a high impact activity, there's high mechanical stress, and you really want it to be elastic because then the hyaluronic acid functions for shock absorption. So rheology is really the study of the flow of matter. And in this case, we are discussing the flow of matter in hyaluronic acid. So if you look at a young patient, there's both viscous as well as elastic properties in the synovial fluid, which primarily comes from hyaluronic acid. You can see that as you progress from sedentary to a higher level of activity, the property of viscosity starts to slowly drop, whereas elasticity starts to increase. And the crossover point is before walking, and that is at 0.4 Hertz. In an older patient, both viscosity and elasticity drops, and the crossover point increases to about 0.7 Hertz, which means that a higher level of activity is required because before elasticity becomes the predominant property. And in osteoarthritic knees, you can see there's further reduction in viscosity as well as elasticity. And in addition, there is no crossover. What that means is there's no shock absorption possible. So in osteoarthritic synovial fluid, the reason is the hyaluronic acid becomes depolymerized and it thus loses its rheological properties, and in turn, this may contribute to cartilage degradation. So now we look again at the comparison of the viscoelastic properties of young synovial fluid. You can see we have discussed that already, the crossover at 0.4 Hertz. So in Hylasto S, the studies show that essentially they're able to achieve a higher level of viscosity as well as elasticity compared to young synovial fluid. And in addition, the crossover frequency also occurs at 0.4 Hertz. What that means is the rheological property is very similar to that of a young human being. So to summarize, for the first to fourth generation hyaluronic acid, they essentially act as viscosupplements. In other words, they are mainly acting as lubricating agents. But in the fifth generation hyaluronic acids, which are viscoadaptive, they have that crossover frequency, they have viscoelastic properties, and in so doing, they probably act as better shock absorbers. So the next property is the ability to break oxidative loops. If you look at the osteoarthritic process, what happens is with osteoarthritis, there's mechanical cartilage destruction. This causes inflammation, and together it causes production of oxygen-free radicals. These radicals have an effect on causing more inflammation. They decrease and they cause degradation of hyaluronic acid, and they cause damage to the chondrocytes as well as the synovial sites. All these create more inflammation, release of pain mediators, which create pain, and together this creates a positive feedback loop, creating more mechanical destruction of the cartilage. So how Hylasto S does work is it stops this process. Okay, the sorbitol, which is an antioxidant, acts on the oxygen-free radicals, and in so doing, it inhibits the processes of the inflammation. And the hyaluronic acid, with its anti-inflammatory as well as rheological properties, help to limit the damage to the cartilage. We need to understand this concept of oxidative stress. So essentially, there's usually in the body a balance between the antioxidant as well as oxidative damage arising from the reactive oxygen species. So usually what happens in osteoarthritis is there's this imbalance where the damage exceeds the repair that is possible. So what happens then if you add an antioxidant? This will help to promote the antioxidant defense system and improve repair. Currently, most hyaluronic acids available in the market do not have the presence of antioxidant within their formulations. And if this balance is disrupted, you would expect that with more oxidative stress, the joints will be subject to more damage. The next property is the improvement of cartilage elasticity. So again, Hylasto S together with hyaluronic acid helps to restore chondrocyte homeostasis. In osteoarthritic patients, there tend to be more catabolic factors that cause damage to the cartilage and less anabolic factors leading to the formation of cartilage. This is due to, again, the change in the properties for shock absorption and lubrication due to the degradation of hyaluronic acid, as well as the inflammatory processes that follow. In treating them with Hylasto S, what happens is we can see that it is more viscous and elastic than young synovial fluid, which you've already seen. And in so doing, what we are hoping to achieve is to balance the anabolic and catabolic factors and thereby limit the damage arising from osteoarthritis. Finally, Hylasto S has unique viscoantalgic effects, which means it has a good effect on pain. As you've already seen this already, most other HA injections limit cartilage damage through purely the HA effect. Whereas in Hylasto S, not only does it have this effect, with SORBITOL, it limits the oxidative damage in the knee joint. And in so doing, it helps to prevent further cartilage damage. So, if you look at the viscoantalgic effects, we can see that Hylasto S has fast, intense, and sustained pain relief. Hylasto S, if you look at the studies that's arising from that's been presented in the overseas congress, we can see that there is reduction in both pain as well as function scores within the first week of injection. Following that, this effect is sustained all the way up to 24 weeks. So this is much faster than what has been reported for most other hyaluronic acid injections. So not only do you have fast pain relief, but you also have sustained pain relief. So let's summarize again. Hylasto S provides fast pain relief as early as 1 week after the first injection, and 70% of these are responders. It provides significant pain relief, as most patients report about strong pain relief immediately after the first injection. 79% of patients have little or no pain after 2 weeks. And the pain relief is controlled after 65. Pain relief is controlled in 65% of patients, still reporting improvement in joint function after 6 months. In addition, co-medication is reduced by 73% for Hylasto S patients. So what we see is there's a unique synergistic effect between hyaluronic acid and sorbitol. The hyaluronic acid providing lubrication, shock absorption, as well as restoration of the viscoelastic properties of healthy synovial fluid, and the sorbitol providing antioxidant effect that protects against degradation of hyaluronic acid and reduces inflammatory response within the knee joint. What then happens is they perform together in synergistically to provide a high performance gel formulation. And this has been shown. So if we look at accelerated degradation studies using H2O2 as an oxidizing agent, we can see that when they are subject to an oxidative stress, the degradation in Hylasto S is only about 22%, as opposed to as much as 60 to 90% in other hyaluronic acid formulations. So in so doing, what this means is that Hylasto S is 3 to 4 times more resistant to degradation than other HA-containing formulations. So to sum up, how does Hylasto S actually relieve the pain in osteoarthritic patients? For the cartilage, normally osteoarthritis leads to thinning, destruction, as well as altered quality of cartilage. And the pain is due to the decreased shock absorption as well as increased pressure on the subchondral bone. In here, Hylasto S protects the cartilage and improves shock absorption, and therefore decreases pressure on the subchondral bone. In osteoarthritis, the effect on subchondral bone is ebonation. It causes tension onto the periosteum, and it causes the development of osteophytes, and all these activate nociceptors. So Hylasto S in this case decreases pressure on the subchondral bone as discussed earlier, and it reduces friction by improving the rheology, and it has a direct effect on reducing the activation of nociceptors. In synovial fluid, the decreased concentration of, as well as the altered quality of hyaluronic acid causes alterations in the rheology of the synovial fluid. Here, Hylasto S improves the rheology of synovial fluid. And in the synovium, it causes osteoarthritis causes inflammation, and here Hylasto S provides a direct effect in reducing inflammation, as we've discussed through the mechanisms. So let's look at some of the clinical studies that have been done on Hylasto S. In a large study involving 1,147 patients, where Hylasto S was injected, you can see that it was significant and safe reduction, both in terms of joint pain as well as functional impairment for patients with osteoarthritis. And this is in all grades of all Calgren-Lawrence grades. And the effect is lasted for 24 weeks. In another study, we see that the addition of sorbitol to hyaluronic acid actually reduces the onset of action of viscosupplementation, allowing pain relief to be achieved as fast as 1 week. So improvement was achieved much faster and is much more sustained. And if you look at another study that looks specifically into high-grade knee osteoarthritis, for which corticosteroids is contraindicated, what you see here is there's already quick and strong pain relief arising after the first injection of Hylasto S. And the benefits were still noticeable at the end of follow-up at week 26, although most of the patients, that is 10 out of the 11 patients, had grade 4 Calgren-Lawrence osteoarthritis damage. And this is despite the absence of corticosteroid therapy. And this is another study that looks at viscosupplementation into the hip joint. What we see is, although 3 injections were given in this case, you can see that maximum improvement can be reached at 6 weeks. And this was sustained up to 24 weeks, and there were no major complications associated with the injections. Finally, you see, this is a basic science study where they subjected human cultured chondrocytes to oxidative stress as well as various cytokines that may induce apoptosis. What the authors found was that there was a beneficial effect of HA and sorbitol by reducing and restoring the balance of the redox status. Essentially, in osteoarthritis, you tend to have a higher level of oxidative stress. And with the injection of Hylasto S, this restores that balance by providing an antioxidant effect. In addition, it reduces chondrocyte apoptosis, inflammation, as well as catabolism involved in cartilage damage. Therefore, in summary, I think intra-articular injections do play a role in the management of mild to moderate symptomatic osteoarthritis that have failed other forms of conservative treatment. Hylasto S provides both viscosupplementation as well as viscoadaptive properties, which is unique to its formulation. The addition of sorbitol helps to reduce oxidative stress in osteoarthritis and retards the degradation of the properties of hyaluronic acid. So they both have a synergistic effect on each other. And the clinical studies show the efficacy of Hylasto S in providing pain relief and improving outcome scores in osteoarthritis. Thank you.
Yeah, excellent talk by Dr. Po. A lovely description about the product as well as about the latest management in osteoarthritic therapy. I would now request our panelist, Dr. A.K. Mitra sir, to share his thoughts about and his experience about using a product like Hylasto S. For so many decades, he's been using this molecule, and he can give his insights and ideas about the product. Over to you, sir.
All right, thank you. And, thank you, posing you. It's a nice talk. And okay, regarding this particular product, it's in marketing in Singapore as a Synolis, and I'm using this product over the last 5 years since it's come out in the market. And my personal opinion over the last 5 years using this particular product will be because I make it indication between 2 groups. One group, I put it as a patellofemoral osteoarthritis, which is fairly common in young, middle-aged person. And second group is the tibiofemoral osteoarthritis. Though there is no known treatment for patellofemoral osteoarthritis, which can conclusively say that it will work. So if there is no other problem for patellofemoral osteoarthritis, that's what I mean, that patient do not have any tight IT band, there is no tight hamstring, there is no dysplasia at the patellofemoral joint, and patient present with grade 2 to grade 3 patellofemoral osteoarthritis. Beside the conservative treatment, I also treat them with this injection, but I use 4 ml. And this 4 ml injection, I know just now Posing you mentioned that in India we are using at 2 ml. I don't see any objection on that, but I grown up with 4 ml and so have seen enough experience on 4 ml to 6 ml. So I just choose 4 ml. And normally, I think there are all the orthopedic surgeon in India, everybody has got their own method how to inject. But basic principle remain the same, that preparation of the skin and to make sure there is no inflammation or effusion on the knee, and make sure there is no skin damage like any skin related disease. So as long as it's not any local complication, and in general complication, definitely diabetic, I will not give a patient which is uncontrolled diabetic. And I rule out these 3. And once I rule this one, then I give the injection. Usually I give it always in anterolateral portal. And it's much easier for me to use that anterolateral portal because over the years we all grown up with arthroscopic surgery, so it's much easier. Lateral portal and superolateral portal, those who are used to, I have no objection on that. And my personal preference would be the anterolateral injection. And I have certain post-injection management. That means all of them immediately after injection, I have a cycle movement of the knee, but I do not extend the knee. So that means the range of movement will be between 30 to 90. So after a few cycles of 30 to 90, then slowly I progress to 20 to 90, then 10 to 90, then complete extension. And it's because this injection is in front of the ACL. So sometimes it's like a gel. If you suddenly want to extend, then there is like a sudden block. And until the knee, you go through a certain cycle and make sure knee is extended completely, only then I allow the patient to come out of the couch. And so this is the immediate post-injection treatment that I provide with my patient. I always tell the patient to use the ice pack at least twice a day, if possible. If not, at least once a day for 15 minutes. And then I always prescribe 3 doses of coxib, whether it is celecoxib or the coxia, which is in here, we got it. And I tell them not to go into any contact sports for at least 10 days. And so these are my, everybody will have this post-injection advice. Now, hyaluronic acid has got this problem of you don't know when it will flare up and who will going to get this flare up. And by chance, if they do flare up, then I haven't seen one infection. So, but I have seen flare up. So if there's a flare up, I never aspirate the knee. I leave the flare up and treat it conservatively with the ice pack and continue with NSAID therapy. And usually they settle down within 10 days. So that's what I do. But be careful. I'm not sure because I never, in the last 35 years, I never seen one infection following this injection. And so now the problem that can happen, now the group of patient is one group is a young with patellofemoral osteoarthritis. They tend to get a bit more pain. The man usually get more pain than the female. So if you have a middle-aged man, they will complain more pain than a middle-aged female. So whether it has to do with the intercondylar notch, or is it because of the female do have a more pain threshold, I'm not too sure, but this is my own observation. So in a young person, and if I want to inject, then I always give 5 ml of either the lignocaine or marcaine, whatever the available in India. So I always add on marcaine or lignocaine. So I inject first the marcaine and lignocaine, and followed by I inject the 4 ml of the Synolis that available here. So this is the main issue, is the pain. The younger generation, that means 30 to 30, 40, they do get pain. More elder they do not get that much of pain. The another group do develop a lot of pain is the group which has got very advanced osteoarthritis, which supposed to go for a knee replacement, but they refuse. So these are the group which has got lot of varus or valgus deformity, bone to bone contact, and this is the group ACL is already degenerated, intercondylar notch has already more or less closed. These are the group get a lot of pain. So these are group I always give lignocaine along with it. So I give lignocaine, make sure there is no wait for at least 4 to 5 minutes. Then I give the Synolis injection, and they feel definitely much better. So these are the few the common practice that when I treat, I make sure that I divide the group with the patellofemoral and the tibiofemoral. Then I divide whether it's a grade 2 to grade 4, and whether it's a male or female. And is, when if you inject few people, after a while you get to know who has psychologically more worried about the injection than anything else. And so be careful about that and inject some painkiller to start with, and they feel better. So now what happened, because in the last 5 years, my personal experience of this injection, definitely they do get pain relief very fast, no doubt about that. Then the other injection that I used to get. So nowadays I tell them that your pain will be much better within the 10 days to 3 weeks. That's what I always tell them, because it has got this anti-inflammatory function. It is the anti-inflammatory function. That's why they do feel, they don't really worry about the osteoarthritis. They come to you because of the pain. They don't know what is behind it. And so as long as the pain is better, they feel better. So that way you can treat it as because it worked very fast. Within 3 weeks, they feel much better. And if you palpate the synovium, some of the osteoarthritis will have a thickened synovium. And I observe some of those patients, especially those who are mid-30s to mid-40s, I could see the synovium also, the thickness change. So there must be some work going on onto the synovium, but how it works, I'm not too sure. But they definitely feel better, and they don't suffer with so much of synovitis. We all know the articular cartilage doesn't have enough supply. So definitely most of the pain is related to either the synovitis, whether direct or indirect way of posing you already described, the whole procedure, how it. And now question is, what happened when you inject these synovials? What happened to the synovials? Where it goes? And definitely it will all absorbed by the synovium. And then it is the synoviocyte that produce the synovial fluid, and which has got all the good things that in life that Posing you has already described. So definitely because it has absorbed by the synovium, maybe that is the reason they do the synovitis associated with osteoarthritis, they feel better. So, and then post-surgery, the eyes and definitely cool down the more synovium inflammation. So this way, my personal experience of this injection is definitely it worked. It worked for the first 3 weeks. They feel better, and in general, quite often they do come back and to have the second injection. So in the 6 months later, though they do not have much problem, but they want an injection because they don't have it. They do feel better. And Singapore, fortunately, the patient have a lot of money, so they don't mind to spend more money on for another injection, and I happily give. And so that's what we give for 6 months, 9 months later, and to review that. Sometimes 1.5 years later, I have seen in MRI scan as well what happened to pre-injection and the post-injection MRI 1.5 years later. Do they recover? No. But do they cartilage maybe from grade 3, especially the patellofemoral osteoarthritis, do they get grade 2? Yes, some of them do get to get 2. But is it due to the injection or is it due to the associated treatment? Like I allow them to do a lot of cycle, I allow them to do a lot of swimming, I allow them to do a lot of stretching exercise. Whether it's the combination reverse the process, I don't know. But I've seen some patients do recover. But once they are grade 4, they never change. It is the grade 2 to grade 3 within that range. Grade 4 remain grade 4. So, so for the treatment point of view, and definitely we can inject this as a, I use it more or less as, the NSAID has a lot of complication. It has got effect on the stomach, it has got effect on the kidney. So I rather give this injection, which is little bit more costly than the NSAID, but overall it's safer and it works. And on that basis, I treat my patient, and over the years, I don't have any issue regarding the management. That's my personal opinion regarding the injection, and that's what I do. Now, if you have any question regarding the issue of the injection, issue of this, both of us happy to answer that.
Sure, sure. So we have
another things, if I don't mind, I'm sure a lot of doctors in India might be listening or watching. Yes. Some of them might have spent with us in Singapore General Hospital, and I welcome them. And I'm happy to, I can't see them through this, but is welcome. Sure. And just to say hello on our behalf.
Absolutely, absolutely. Right. Yeah, so we've got a few questions now from the audience. So it's for both Dr. Poh as well as Dr. Mitra. So we'll start with Dr. Poh first. So there is one question regarding your management protocol. Once you inject the patient, do you call back the patient the very next day or after 2 days to reassess his movements? That is one. Yeah, sir, you're on mute. You have to unmute yourself.
Okay. No, usually not. But okay, so even before the injection, we do quite a thorough discussion about what they should expect. So a few things I tell them is, there's a risk of local flare as well as risk of infection. Okay, so usually after the injection, we tell them, if the knee suddenly becomes swollen or inflamed, first thing is to do take the NSAIDs. Okay, if they say the pain and swelling starts to get worse or they develop a fever, then I will let them come in directly either through the clinic or to the A&E. But otherwise, there's no rush for me to see them like in the next 1 week or so. But all my patients after injection, I do quite similar to what Dr. Mitra does. I will cycle the knee, okay, after the injection. Usually we keep them in the clinic for maybe about 15 to 30 minutes, just make sure they're quite comfortable and walking nicely. And then after that, they go home. All of them get a 3-day course of NSAIDs, at least 3 days, just to avoid the problem of the local flare if it occurs. And like I said, from my own experience, local flare is maybe less than 1% of my cases. And similarly, I've seen patients who came in with infections, but I personally don't have any case of septic arthritis arising from a hyaluronic acid injection. But you have to be just careful with the aseptic technique. That's the most important thing, I feel. Yeah.
So do you give all your patients in the local OPDs, or you like to inject in the operation theater?
Oh no, for knees, all in procedure room. For hips, because I use fluoroscopy mainly for the guide, then I do them in the operating theater.
Right.
Yeah, but nevertheless, they all go home the same day.
They all go home the same day. Right. Yeah. So the next question for you again, sir, Dr. Po, is the protocol which, like, after you have injected the patient, say it's a patient who's above 60 years of age,
right.
He's taking the injection, and then would you keep him indoors for the next 48 hours? You ask him to stay indoors or do very mild basic activities, or he's free to move around in the next 48 hours?
Okay, so generally I allow them to go back to regular low impact activities. That means they're not supposed to do any contact sports or high level of activity. But simple cycling, walking, I think that's not a problem at all. Even stairs and things like that. So normal daily activities, but I would encourage them not to specially do sports. Just to prove whether the injection is working. So I tell them, let them wait for the analgesic effect to come into play first, and then slowly build up the activity from there.
Right.
Yeah.
Fine. That's excellent. Next question for Dr. Mitra. Sir, there is one question for you saying that would you like to inject in stage 4 arthritis as well?
Okay, the stage 4 arthritis, as I mentioned earlier, I inject for the pain. It's not because of the articular cartilage. So it is the synovitis that come along with the osteoarthritis. So definitely for that kind of, I mean, if it's a grade 4, and most of them require surgery. Most of them require surgery. Some of them might want to delay the surgery. Some of them might not want to do the surgery. Some of them might want to do the surgery a few years later because of their own personal problem. I have to tide them over. And that's what I do. I tide them over with the injection. They also know, I also know that it is not the management, but it is actually to relieve some synovitis and relieve some pain. That's what they know. And their expectation is not too high because they know already that it might work, might not work. I tell them straight away that we'll give you this chance. If it works, fine. If it doesn't work, better prepare to come for surgery.
Right. Excellent, sir. So another question for you, Dr. Mitra. This is regarding the procedure. Like as you said, you're using the aseptic techniques. You're giving the injection either in your procedure rooms for the knee joints. But suppose in cases patients have got some sort of hypersensitivity the moment you inject. So what is the protocol you follow?
If it's a hypersensitivity, which I have not seen one, and if there is a hypersensitivity, then it has to be the lignocaine, not the hyaluronic acid. And we have in the ward and in the clinic also, we have all the facilities of giving all the anti-allergic injection. We have steroid, we have the adrenaline, we have everything that we want to give. It's all available. So just I can give it a 100 milligram of hydrocortisone, or just straight away IV, and that's okay.
It takes care of it.
Job done.
Right, sir. Dr. Po, a question for you.
Yeah.
This is about, again, the injection part.
Yeah.
Some people say that who have used, or some people have seen our injection, they say this is a gel type of an injection.
Yeah.
Any difficulty in giving it during administration? Do you find any resistance when you inject?
Yeah, actually, personally, okay, of course, it's not the same as injecting saline. You know, obviously there is some resistance, but generally the flow is quite smooth. I think it's important for you to use an 18 gauge needle. Okay, so I don't try to get the really small, like 22 gauge needles. You know? Yeah, so if you use an 18 gauge needle, usually there's no problem. For the knee, I think a few things you need to be careful, because if you advance your needle too deep and you're in the substance of the ACL, then you're injecting against the ACL, then obviously you feel a lot of resistance. Once you feel that, like I said, withdraw the needle a little bit and push, and then you will get a nice flow. And even in the hip joint, when we inject, you know, the hip joint is typically very tight. Yeah, so, and even then, there's no real issue with the flow. Yeah, so I always do a test injection for the hip just to make sure the flow is established. Then I just inject the hyaluronic acid. There's usually no issue at all. Yeah.
Right, right.
Dr. Patel, can I come in?
Sure, sure, sir. Please come in. Yeah.
I did mention in that advanced osteoarthritis, when the intercondylar notch can be narrow.
Yeah.
Right.
Now, there's another group which I have not mentioned, which, as you come on that question, so I better answer that one as well too.
Right.
If the patient had arthroscopic surgery previously,
right,
they have scarring
Yes.
within the knee.
Absolutely.
So once you have the scarring within the knee, they will have pain.
Right.
So you have to be careful with that group of patients. Must have lignocaine or marcaine or xylocaine, whatever available to you, inject that one first. Now, there can be a lot of controversy on it, because these are all, it affect on the articular cartilage. But articular cartilage is already destroyed, so I'm not too sure.
Right.
Now, second group that those who have proximal tibial operation and or the intra-articular fracture, whether it is the tibia or it is the femur, that's the group which has eventually might have surgical procedure and then develop osteoarthritis.
Right.
And that's the group will have more pain. So be careful about patient who had an open surgery for the intra-articular fracture, those who have an arthroscopic surgery. These are the group you need to be a bit careful, and you will have difficulty to inject.
Yeah.
Sometimes you really have to force to inject that. So 4 ml, you need to really force it, and that can be painful.
Right. So this is greeting has come to Dr. Mitra from Dr. Suraj Prakash from India. He says that I spent some time with him long back ago, and he wants to ask you a question for grade 2 and grade 3 osteoarthritis.
Okay.
What amount of relief you promise to your patients?
You don't promise anything. Anyhow, in osteoarthritis, you don't promise anything. You can promise that the 3 things I tell them. Number 1, that and by the way, say hello to Suraj as well.
Sure, sir. Sure.
Okay, and the 3 things I tell them. Number 1, it will reduce the inflammation so that your pain will be better for a while. It will slow down the further damage. It is a chondroprotective. There is no proof that it can reverse the procedure. That means if you are grade 3, it will not go into the grade 2. So as long as everybody I tell them the 3 things, your inflammation and the pain will be less, your cartilage degeneration will slow down, and it might reverse if it's a grade 3 or is a grade 2, but must have associated management, not the injection alone.
Right.
So as I mentioned just earlier, the patient if has a say patellofemoral OA with a tight IT band, or it's no point to give an injection and the patella has a tilt, has a subluxation, and you expect everything will be okay. So that should be, along with that, there should be other treatment to make sure correct those as well. Only then patient do feel better.
Right.
Tibiofemoral osteoarthritis, once I always feel the synovium. Every osteoarthritis, I feel the synovium and see whether the synovium is thickened, inflamed or not, tender or not.
Right.
And that judge, all the injection I judge based on the synovium, not so much onto because I know that I can cure or at least diminish the pain.
Right.
So that's what I did.
Right.
So main issue is to relieve the pain.
Right, right, sir. Right. So one more question before I hand it over to Dr. Neeraj. So this is a common question which has come from many doctors in India. Now this is for both of you all. Both of you all can take this one by one. The question is, in today's COVID-19 scenario, especially which is going on in India right now, we have still not unlocked ourselves completely. So patients, especially in grade 3, grade 4 arthritis who need surgery, and because of these circumstances, the unprecedented times, we are not being able to operate them. Would you recommend them as a precaution or as some modality to reduce the pain, they can take an Hylasto S injection? So Dr. Poe and Dr. Mitra can take it one by one. So Dr. Poe, first your comments on that.
Yeah, certainly. If let's say that okay, for any reason, if the patient is unwilling at this point of time to go for elective surgery, or logistically it's not possible, and certainly the use of a hyaluronic acid injection or Hylasto S as an adjunct to help with the pain relief and reduce the inflammation, I think is definitely warranted. And for all it may be able to tide them over for a significant period of time. So I would say I would consider the use of an injection.
Right, right. Dr. Mitra?
My answer is very simple. In my opinion, life is more important than the knee. So you never know the surgeon who is coming the patient coming for the injection carrying the COVID or not.
Right.
You might not you might not carry it, but you never know whether you are exposed to the patient. Right. On the other hand, you may be exposed and the patient get it from you.
Right, right, right.
So I don't see any emergency here that need to give the injection. I would rather stay safe.
Right.
In this time.
Right.
The play safe, because remember, it's not only the patient, the family also come into play.
Right, right.
And the doctor's family, patient family.
Right. So, but the patient insists for an injection, then what should be the?
We went through the same thing.
Right.
When we went through the COVID, we call the patient and we tell them straight away. I tell them, the patient, life is more important than your knee. So when things settle down, come back.
Right, right.
And they will happy to come back. They will not come. I tell you straight away. They will can automatically can. They also frightened. Forget about the doctor. They also frightened.
Right, right, right. Because so what we have seen, because in India, as you know, the lifestyle is pretty different. Our patients love to sit on the floor. So the amount of pain they are at stage 4 of arthritis is very challenging for them as well. So we have seen that many of these doctors have experienced that. The patients do want them to come. So
as long as the doctor himself thinks that he is not suffering, and the patient thinks that he is not suffering, it's okay.
It's okay. Perfect. Perfect, sir. Thank you, sir. Thank you. So Dr. Neeraj, over to you.
Yes. Thank you very much. I think Salim has covered most of the topics and all the questions which were coming to my mind also, and the audience also. So we thank Dr. Poe and we thank Dr. Mitra to spare their time on a Saturday evening where they should be spending time with their family. And they have spent a good enough time with us on OrthoTV and the Zydus platform. And they have given us new information on Hylasto S and the main advantages of it, especially in today's scenario where we can use it even in grade 3 and very rarely in grade 4 KL patients also. So I thank everyone and thank Dr. Salim Patel. And with this, we would end the meeting. Thank you very much and bye-bye.
Thank you.
Dr.
Thank you all of you.